Hello, everyone. Welcome back. This is chapter 18. We're going to talk about the drug therapy for dysrhythmias. Actually, the chapter starts on page 291. So we're going to go basically through the quick part of the electrical system of the heart. And we know the electrical conduction system is what controls everyone's heart rate and rhythm. We know the normal pacemaker of the heart is the SA node, the sinoatrial node, and we know that that would be the rate of 60 to 100 beats per minute, and that is the pacemaker of the heart. Um, we know that electrical impulses of the heart, it starts with the SA node, the pacemaker, then it travels to the AV node, the atrioventricular node, then it goes to the bundle of His and the Purkinje fibers. And that's how the electrical system goes, and that's how our heart beats. So that is something to look into. So with our SA node, like I said, it is the pacemaker of the heart, and a normal heart rate for that would be 60 to 100, and that is considered a normal heart rate. Um, then we deal with if something happens with the SA node, if something's wrong with the pacemaker of the heart, what happens next is the AV node will take over, that atrioventricular node. And when the atrioventricular node takes over being the pacemaker of the heart, then what happens? The heart rate will decrease, and then you will get a heart rhythm of about 40 to 60 beats per minute. So that will be the second one. If anything happens to that AV node, so now we have the SA node is bad, the AV node is bad. What happens next is the bundle of His and the Purkinje fibers start to take over. And that is when you're going to see people with the heart rates of 20 to 40 beats per minute. And that is not going to help much for sustaining your life. So that is when we have like a lot of issues and we have to make sure everything's okay. So, like I said, SA node is our pacemaker. If something happens, the AV node takes over, and then after that, the third pacemaker will be the bundle of His and the Purkinje fibers. Remember, at the rate of 20 to 40 beats per minute, your body is not getting the oxygen or blood it needs to survive. So these patients will start becoming confused and they will have a change in mental status. And that is a lot of times when they come into the emergency room is because of that. A lot of times they don't realize that their heartbeats are going down. And then we have this issue, and by that time the rates are very low, and then we have to start pacemaking, put a pacemaker and pacemake these patients. Um, so those are some things. So on page 293, you can actually see the different conduction system of the heart, as well as you can see normal heart rates for the different age groups. Now remember, adults, a normal heart rate is 60 to 100. Anything less will be considered low. Anything above 100 is considered high. In children, the levels are going to be a little different. It's 70 to 120, toddlers 90 to 150, and of course infants are always going to be higher, so they're about 120 to 160. But when they're crying, it's really high. If they have a fever, it can get really high, sometimes into the 200s. We've seen it. So just depending on the situation, that can change. But those are considered normal heart rates for the different populations. What activities that can cause a low heart rate? Well, sleep. Sleep will definitely cause a low heart rate. So sometimes you'll see a patient actually drop a little bit when they're sleeping. If you're resting, maybe you were doing some activity and then you decide to rest, that's going to actually decrease your heart rate. A lot of medication can decrease your heart rate. Remember, we talked about Digox and how important it is to make sure we check that heart rate because it will lower your heart rate. So we want to make sure that that level is at least 60 or better before we give that pill. Meditation can also cause your heart rate to go low. Your body needs less oxygen, so your heart rate can go even lower. With activities, it can cause your heart rate to go higher. And that would be exercise, excitement, fever, shock. That's when your body needs a lot of oxygen, so your heart starts beating faster to make sure that we get that oxygen to the tissues that it needs. And then it's going to make it go higher and higher and higher. So that's why we're going to see those heart rates go up, especially when they have fevers, if they're in shock, if they're excited, if they're exercising. It's because the heart is trying to give the demand that the body needs and provide that oxygen. So it has to pump more and more and more to transport it to the area. When we hear the word normal sinus rhythm, that is the rhythm produced when the impulse travels from the SA node, which then which causes the atria to contract, and then it travels the electrical impulse until the ventricles contract. And the rate it takes to do is about 60 to 100 beats per minute. On page 294, let me flip the page, you can actually see the different types of heart dysrhythmias that can occur. Okay, as well above that, you see that little figurine, the PQRST complex. That is what a normal sinus rhythm looks like. Every beat should have the same. Okay, it should be normal. When we have slow rates, and originates at the pacemaker at the SA node, but it's going at a slow rate, we call that bradycardia. And in this case, you're going to see that complex, but it's going to have long little pauses in between, but it's going to be regular. Now, when the rate starts to get faster, greater than 100 beats, and it originates at the SA node, that is where you get tachycardia. So that's anything above 100 beats per minute. So anything less than 60 is called bradycardia, so 59 and down, and anything 101 and over is called tachycardia. Okay, but they both originate from the SA node. So we're going to see that complex, that top picture, that figure 18.3, and we're going to see that on every complex. Sometimes when it's in tachycardia, it's a little fast, so sometimes we don't see that perfect complex because it's all squeezed together, but each beat will all be the same and they will be evenly spaced. Now, the lower part, like I said, those are the common dysrhythmias we're going to be talking about. And dysrhythmias are just abnormal heart rhythms. They don't originate from the SA node, but they can originate from impulses in the heart muscle. The heart muscle can either beat fast or slow. These dysrhythmias will actually decrease cardiac output, and we know that's the amount of blood the heart pumps in a minute. So on box 294, those are the common dysrhythmias, and it just depending on where they originate. You can see the ones that originate in the atrium, the ones that originate in the ventricle, and those are very life-threatening ones when they deal with the ventricle. We have junctional rhythms, and then we have heart blocks. We're not too concerned when we're dealing with like first-degree heart blocks. We get more concerned when we start dealing with third-degree heart block, because with third-degree heart block, the heart's not talking. The atrium are beating their own, and the ventricle are beating their own. They're not like the atrium, ventricle. They're just doing their own thing and, chilling out. So that is why we have to watch with that third degree. So those are some different parts, and it just tells you what dysrhythmia and where it originates from. And that's just how it originates in the heart. Atrial dysrhythmias, of course, start in the atria. Supraventricular dysrhythmias originate above the ventricles, supra. Ventricle dysrhythmias originate in the ventricles, and those are the ones that are very life-threatening. And then we have some things called premature beats. These are beats that will be earlier than expected. Sometimes it's just a little excitability and the heart decides, I'm going to take a beat. So it takes a little beat. And a lot of people have premature beats, especially if they do a lot of caffeine. You can feel like a little skipping in the heart and things like that. If you do a lot of, energy drinks, caffeine drinks, sometimes there's just a little bit of excitability. So it's not uncommon for a lot of people to have these premature beats, and it's not uncommon. Now, the premature beats, like I said, are going to be earlier, and there are three types of premature beats. We have premature atrial contraction. That's when the atrium decides to just take an extra beat. We can have premature junctional contractions, and this usually starts in the AV node region. It decides to take an extra beat on its own. And then, of course, what we all feel are those things called PVCs, preventricular contractions. And these ones start in the ventricles. And like I said, a lot of times when people have PVCs, we get a lot of people come in with energy drinks. That's why I mentioned that a lot. But they feel like their hearts are skipping beats. They have few premature beats are okay. Our big concern is when we start having a long run of those premature ventricular beats. That is when it starts to become into a serious dysrhythmia, and it actually will decrease the cardiac output and could lead to death if not taken care of. Some dysrhythmias can cause the heart chambers to quiver, and that's called fibrillation. This means that the atrium, it could be atrial fibrillation or ventricular fibrillation, and that is just they are not doing their contractions normally. So basically, the muscle is just quivering in that area. It's not taking a beat. Now, when we have atrial fibrillation, this is when it's in the atrium and it's quivering and the atrium is not contracting. The bad thing when we're dealing with atrial fibrillation is that blood is not being pushed out of the atrium, and a lot of time it is just sloshing around in there. And what happens if blood isn't moving? It's going to start clotting. So people who are in atrial fibrillation have high risk of getting blood clots. So a lot of times you'll see a patient in AFib, they will put them on some type of anticoagulating medication to help prevent them from getting clots. So you may see them on warfarin, which is Coumadin. There's other drugs out there that they can put them on, just depending on each situation in the patient's case. And we'll be talking about that. I think the next chapter or the chapter after that. I'm not quite sure which one, but we will be talking about that soon about clots. Now, when we have ventricular fibrillation, this means that the ventricles are not contracting. They're just fibrillating. They're just moving. They're not giving a good squeeze. So no blood at all is being pumped out of the heart and it's not being pumped to the body. And if we do not take care of this ASAP, that is going to be death for that patient within minutes. That's why it's important if we have ventricular fibrillation that we start CPR and we defibrillate that patient as soon as possible to try to get them out of that dysrhythmia. In box 290, on page 295 in the boxes, you can see some common symptoms of dysrhythmias. And these are things that people will complain of. And then when they do complain of them, we have to investigate more. So a lot of times if they come in with chest pain, we are going to do an EKG to make sure that it's not their heart. They can complain of dizziness because their circulation of the blood isn't moving right. Some of them can faint because they're not getting circulation, blood pressure is low. They get that feeling in their chest, something's fluttering, something doesn't feel right. I'm feeling lightheaded, I'm going to pass out. Some people have no symptoms at all. You'd be amazed. We've had patients, we put them on the monitor, like, whoa, what the hey is going on? And the patient says, yeah, I just, came in to be checked and, I have a cough or something. And we're like, well, you got more than a cough. And then some will have rapid heart rates, some will complain of shortness of breath, and some will have very slow rates. But these are very serious. Those ventricular fibrillation is very serious. That's the ones we have to make sure we start CPR and try to get that defibrillator and defibrillate that patient as soon as possible. Not all patients with dysrhythmias will have symptoms, like I said, and that's not uncommon. But you can see on page 295 on that box 18.3 the risk factors for developing dysrhythmias. And like I said, age, as you get older, the heart doesn't pump like it used to be. Genetics, we're screwed. If you have bad genetics, you're screwed. Nothing we can do for you. We can try to do preventive measures as much as possible. Coronary artery disease is a big thing. Thyroid problems, remember, with hypothyroidism, it's like the turtle. So your heart rate is slow and low. And when we're dealing about hyperthyroidism, that's fast, 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 fast. It's the rabbit. Everything's going fast. Heartbeat's going fast. So you see a lot of tachycardia. Drugs, especially the supplementals like the cough and cold medicine, like I told you, which has that pseudoephedrine, can cause your heart rates to go up. High blood pressure, obesity, diabetes, low blood sugars can cause a lot of issues, cause that hypoglycemia. sleep apnea, obstructive sleep apnea, if you have electrolyte imbalance, that's going to cause dysrhythmias, especially remember our potassium, sodium, calcium, and magnesium. Big, big thing for heart contractions. So we have to watch with that. Alcohol abuse, that can cause dysrhythmias. And of course, a lot of stimulants that we use, a lot of caffeine, a lot of nicotine. And like I said, those energy drinks that people drink, they come in all the time because they're filling those extra beats that occur. And of course, illicit drugs, cocaine and amphetamines, because those speed the heart up and can actually cause a heart attack in a patient. So those are some things that can actually make a normal heart develop dysrhythmias. And some of them can actually kill you, especially if you don't get them under control. So those are some things that we have to look at when we're dealing with these, a lot of those. Now, where do we measure for an apical pulse? Now, when we're dealing with people, we should always listen to the apical pulse. Even though we have a monitor on the patient, we should always listen because we want to know what we're hearing is what we're seeing on the monitor. So, where we check is on the left side of the chest, fifth intercostal space, mid-clavicular line, 2 fingers below the left nipple. Okay? Now be careful. Some people's nipples are down to their knees, so that's not going to apply to them. So that's why we have to go to the, fifth intercostal space uh, and kind of estimate where the nipple would be. But anyway, a little jokey jokey for there, a little laughy laughy. But we want to make sure we listen for a full minute, and we want to listen to the rate and listen to see if there's any irregularities. Is it beating normal? Does it have a nice loved up? Or is it lovey dub dub dub, different sounds. So that's what we're kind of listening for. Is it a nice pattern or is there an extra beat in there? And when that occurs, if you do have a monitor, you should be listening and looking at that monitor to make sure that it's correlating with what you're sounding, or what you're hearing, not sounding, what you're hearing. Also, when we take people go home, the only issue is a lot of them do not have stethoscopes to listen to their apical pulse. So we're going to teach the patients how to feel for a radial pulse and to know if the heart rate is normal or if not, or if they're feeling something irregular. And that is something we're going to have to teach them because a lot of them, like I said, do not have stethoscopes. So we're going to talk about antidysrhythmic drugs. Antidysrhythmic drugs, surprise, surprise, are used to treat abnormal heart rhythms. They are prescribed to increase or decrease a heart rate. Okay, if you have a low heart rate, we want to increase it. If you have a high heart rate, we want to decrease it. So we use different drugs to try to help prevent that. If you have any liver or kidney problems, we're going to prescribe you lower doses to make sure we avoid overdose or toxicity of that drug in the system. We're going to make sure before anything we obtain a list of all your allergies, anything prescribed, as well as over-the-counter drugs, because we know some of those allergy medications can cause increase in heart rate and blood pressure, so we have to watch that. We want to make sure we obtain a base weight line because a lot of these drugs will be weight-based, and we want to make sure we get a full set of vitals. Blood pressure and heart rate are going to be the most important. And we want to listen to the apical because that's in that, and listen to make sure are there any dysrhythmias or heart problems. So that is why we want to make sure we do an apical before we give any of these drugs. Having the monitor is always awesome because we can look at the heart strips and watch for changes, and if they occur, we can notify the doctor. So that's nice because a lot of those machines, they will record it, and then we can pull it up and pull that strip and show the physician what happened at this time. Maybe the patient started complaining of chest pain, and then when you went back in the monitor, you noticed that they had some weird beats. So you want to make sure you print that strip and give it to the doctor to look at. After we give these drugs, we're always rechecking the blood pressure, the heart rate, the rhythm of the rate, and all that. We're going to make sure the patient uses the call light before they get up because they can become dizzy or lightheaded with these medications because these drugs can decrease the blood pressure. So we want to make sure that they change their positions very slowly. We don't want them jogging to the bathroom, especially after their first dose. Please, 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 please. I always tell them, please call me. At least let me make sure you're okay before you get up. I don't want you falling and getting hurt. Never double dose pills if you missed a dose, and watch taking over the counter meds unless it's okay by the physician. You always want to double check things and talk with the pharmacist because they can recommend if something will be good or not. And always they recommend if you have any type of cardiac dysrhythmia to wear a medical alert bracelet because if any time in need, if you're not alert, you're out of it, then what we can do is we know by the medical alert bracelet that you do have an issue, and then we can make sure that we look for those problems. Okay, so when we're talking about dysrhythmias, I don't expect everybody to know every dysrhythmia in the world, but we have two dysrhythmias that we're going to be saying. We're going to talk about slow dysrhythmias, so bradycardia, bradyrhythmia, dysrhythmias, and we're going to talk about tachyarrhythmias. So we know anything that is a brady um, dysrhythmia, that is a very slow heart rhythm. These are rhythms that are going to be less than 60 because it's Brady. Okay. And if you go to page 297, for any low heart rate, the drug of choice that we give is atropine. Okay. Atropine is what we can give. It is the drug and the choice to help with this if your heart rhythm is low. Okay. Usually when we give it, it is given IV. It is given by an RN. To make sure that we can see if we can increase the heart rate. We use this drug when people are showing signs and symptoms of bradycardia. Now listen, a lot of athletic people have low heart rates less than 60. Does it mean I'm going to run and start an IV and stab them with atropine because their heart rates are very low? No. We only give atropine if the heart rate is very, very, very low. I've given it when it's in rate of 20, 30, sometimes even 10. We will give it, and they're showing actual signs and symptoms, signs and symptoms, and that is when we're going to actually give it. So there has to be some type of signs or symptoms before we will give it, because there are very healthy people that do run low, especially our athletes. They can run sometimes in the 40s. I've seen, 40s up to 60s, just depending on how well they have their, workouts. So the only time we give atropine is for symptomatic bradycardia. There has to be some symptom that they're complaining about. We do use for people who are asystole, and that is asystole means there is no electrical activity coming from the heart. It is flatline. This is the boop that you hear a lot of times on the TV thing. There is no heartbeat, there's no heart rhythm. So we will give atropine to help with that. If we don't have any IV site, Ativan can be given through an endotracheal tube. So if the patient is intubated, we can actually put this down the tube, and we can bag it into the patient, and if we do not have an IV site. So it is one of the drugs that we can give down an endotracheal tube. Usually we'll give twice the amount of the dose that we would give, for an IV, because we need more, because IV is, remember, 100% bioavailability. If we're giving it through an endotracheal tube, we need to use a little bit more because we have to circulate it through the lungs and through the system. So it takes a little bit. So a lot of times we mix it with a little bit of saline, and then we will bag the patient so it circulates. If we don't have maybe they're not intubated and we do not have IV access because the patients, can't find any veins, then we can also put in an IO, which is an intraosseous IV site, where we will drill it right into the bone. And this is a awesome thing to do for when we cannot access patients' veins, because a lot of times when they're in these dysrhythmias and that, their veins clamp down and we can't get them, or they just have bad vessels because of their medical condition. So we can actually do an intraosseous in helping us give these medications to bring the patient's heart rate up. So to know what drugs that can be given down an endotracheal tube, we use this acronym NAVEL, N-A-V-E-L. These are the only drugs that we can give down that endotracheal tube to help people. So someone who overdoses, we can give Narcan. Narcan is the first thing that we can give down an endotracheal tube, so someone who's intubated. The second thing is atropine, which we talked about to help bring up the heart rate. We can give Valium, and Valium will help patients with seizures to quit seizures. We can give epinephrine. We give that for cardiac arrest. We also give it for people who are having respiratory problems or allergic reactions. And lidocaine. Those are the only drugs that we can give down an endotracheal tube. So know what the acronym NAVAL means, NAVEL. So no Narcan, atropine, Valium, epinephrine, and lidocaine. Okay, those are the things. So those are the drugs that only can be put down an endotracheal tube. And I know it's on page 297 in that memory jogger on the side. And very important, guys, remember, read those side columns because that's going to help a lot for you. Other uses also for atropine, we can give it to dilate pupils for an eye exam, and sometimes we give it before intubation in emergency situations or surgery to help decrease the production of GI and respiratory secretions. It also helps with laryngeal spasms. It will help with bradycardia when we're intubating, as well as hypotension. So a lot of times you'll see them give atropine before it to prevent some things. This drug will increase the heart rate. That is what it's for. Atropine, if we're giving it for bradycardia, is going to increase the heart rate. And that's what we want. It will increase cardiac output, and that's what we want. We want more blood pumping out of that heart, and it will decrease the symptoms of dizziness and lightheadedness that can occur. But they do come with side effects. So we know if we're giving it for a slow heart rate, one of the side effects is, surprise, surprise, we can cause tachycardia. We can actually cause an increased heart rate. Atropine will cause drowsiness. It will cause blurred vision. It can cause dry mouth and urinary retention. Now remember, I told you that they use atropine a lot of time for intubation to decrease the production of gastric and respiratory secretions so they can intubate a patient without getting all those secretions in the way. So atropine has drying effects. Okay, so that's where, think about it. When you're dry, your heart rate goes up. You get a dry mouth. That's a big complaint they have with that. Oh, my mouth is so dry. Urinary retention, and we have to watch with our male patients who have benign prostatic hypertrophy, prostate problems. We have to be very careful with that. And remember, with blurred vision, anything with the drying effects, we have to watch our glaucoma patients because it can actually make glaucoma worse. So we have to be very careful. And I always think if I'm dehydrated, if I'm dried up, I can get drowsy because I'm tired. So those are the common side effects that occur with, atropine. So those are some things that we have to watch for. Now, adverse effects. It actually can make dysrhythmias worse. It can cause ventricular fibrillation. It can cause PVCs, those premature ventricular contractions, or it can actually cause ventricular tachycardia. And the VTAC and the VFib, those are the two bad ones. Now, the preventricular contractions, those are the beats that you have, those funny beats. But if you get long runs of it, it can lead into VTAC and then into VFib. Another bad adverse effect is ischemia. It can make ischemia of the heart to become worse, because atropine will increase the heart rate and the workload of the heart. And it will lead to the decrease of the blood flow to the heart, and that will cause chest pain, and it can cause ischemia and can cause the patient to have like myocardial infarct issues. Another bad thing that happens with it is that when you give small doses of atropine, usually less than 0.5 milligrams, it can actually make bradycardia worse. This is paradoxical bradycardia. So a lot of times we do not want to give less than 0.5 milligrams because it will make bradycardia worse. So we will either give 0.5 or we will give 1 milligram of this atropine. So before we give atropine, we're always looking at the vital signs. We want to make sure we have a good IV site. We have the monitor intact. We want to know if the patient has glaucoma. We know that this medication can make their vision worse and cause problems, but when it comes to saving their life or not, I'd rather have eye problems than be dead. So a lot of times we will know if they have glaucoma, can make it worse. If the patient is having very low heart rate, we want to make sure we have the crash cart at the bedside, because we may actually have to pace the patient using those transthoracic temporary pacemaker. And those are those pads that they put on the chest, and then we will just start the pacemaking the heart until they can get a temporarily pacemaker or a permanent pacemaker put in. So that's what we will use until that permanent pacemaker gets put in. After we give atropine, we're always rechecking vital signs, heart rate, and blood pressure. We should see an increase in improvement with that heart rate and the blood pressure and all. That's why it's important to make sure we have what the patient started with. We're always going to watch the urine output because we know that urinary retention can occur, and we're going to watch for any other side effects. And make sure we listen to the bowel sounds and check for abdominal tenderness, because atropine can cause constipation. Remember, drying affects constipation. And we're going to teach our patients about atropine. That is not for long-term use. We only use it for when they're having the issue. They're not going to go home with a dose of atropine to take and put it in an IV or something. We, as nurses, we give it as directed. We know that it can cause drowsiness, so safety precautions is going to be a big thing. And we're going to remind them that atropine is not always a permanent fix. It may help bring up the heart rate, but a lot of times you'll see that it will bring it back down. And in those cases, those patients will have to go usually to the cath lab and have a pacemaker placed, a permanent pacemaker. We know that it causes drying effects, so if you have a dry mouth, we're going to give our patients some rinses, teach them how to do good oral mouth care, maybe, rinse a little more frequently. If they have any visual problems and we know that they have, glaucoma issues, we may have to, consult someone in regards to that. We want them to avoid any strenuous activity or the heat, because atropine will affect the body's heat regulation. So they will not tolerate the heat very well because they're not going to be sweating. They're going to be holding all that fluid. Now, pregnancy in the breastfeeding population, it can cause tachycardia in the fetus, so we don't want that. But sometimes you have to give it to mom if her blood pressure is not high. That's going to affect the baby big time. So that's, like I said, that's discussed with OBGYN. Pediatric population, they're going to be more sensitive to the effects of the med, and they can have the same side effects, but we need to watch them very closely. In our older population, you don't want to give large doses of atropine because they are more sensitive to the effects, and it can cause confusion or other side effects. And they are at greater risk for myocardial infarcts because their heart muscle isn't strong enough. And if they've been beating low and then all of a sudden we speed that heart up, we can actually cause them to have a heart attack. So we have to be very cautious with that. And we have to closely monitor them. So that is like the major drug that we use for atropine. Okay. Now, that is used for slow rhythms. Now, when we talk about fast rhythms, we're going to talk about those tachydysrhythmias. And these are those abnormal, rapid heart rhythms in rates that are greater than 100. These drugs work in three ways. They either will reduce the osmoticity of the heart muscle cells, or they will slow down the conduction of the electrical impulses through the heart, or they can prolong the refractory period of the heart cells, where the heart is at rest after a contraction. So it can work on the body in three ways. So on page 299, let me flip on over. You can see some common classes of antidysrhythmic drugs for the tachydysrhythmia. And we're actually going to go through those classifications, okay? I don't expect you, I'm not going to ask you, hey, patient's MD tach, what are we going to give? What drug is most important? Hey, patient is an SVT, I'm not going to ask you that. But just know that these are for fast rhythms greater than 100 beats per minute. And you're going to see the irregularities. Recently, they determined that they want to use less of the class 1 drugs and use more of the class 2 and 3 drugs because the more side effects that those class 1 drugs have. So we're going to be talking about those class 1, those sodium channel blockers. And surprise, surprise, guess what? We've talked about some sodium channel blockers when we talked about hypertension. All right, so these are, remember, for high rates. Now, our class 1 sodium channel blockers, okay, they are to prevent sodium from entering the cells, membranes, causing the heart to slow down and decreasing the heart excitability and the speed of conduction. And we have three subclasses of those sodium channel blockers. Class 1A, you can see what they're used. They treat symptomatic PVCs, SVT, VTAC, VFib if it's reoccurring. And like I said, you don't need to know that. But on page 299, you're going to see the medication that we do use for that, okay, for our class 1As. And these are the common drugs. The goal for them is to slow down the heart rate, make the rhythm more regular, and increase cardiac output. So in this thing, I have used quinidine before. Procainamide is probably the biggest one that we use at the moment. Disopyramide, Norpace, we use that occasionally, probably procainamide out of the class 1, we use more than the others, but not as much as other drugs. But it is out there and I have used it before, just not as much as some of the other stuff we do now. These medications do have side effects, and that is on page 300. They will cause hypotension, and they will cause a lot of abdominal issues. They will cause anorexia, abdominal cramping, diarrhea, and nausea. So you'll have hypotension, a lot of belly issues. Disopyramide or Norpace will actually cause drying effects. So it will cause constipation, dry mouth, and urinary retention. So disopyramide will dry you up. Now, adverse effects for these medications, quinidine will cause hypotension and it can actually develop serious ventricular rhythms called torsades de pointes. And that's something you don't need to know, just know that it can cause a serious ventricular dysrhythmia. Procainamide can cause seizures, heart block. It can actually cause asystole, that's the flat line, and it will decrease your white blood cells. And we know if we decrease white blood cells, that puts you at risk for infection. Disopyramide also causes heart failure. So if you have heart failure, disopyramide might not be the drug of choice to give because it will cause heart failure. And these medications do cause allergic reactions. It can cause fever, neutropenia, that Raynaud syndrome where you have the icy cold hands, muscle aches, skin rashes, and blood vessel inflammation in the fingers. So these medications, these class 1 calcium channel blockers do cause a lot of things. So for class 1s, it's best to give on an empty stomach with a full glass of water. If you do have gastro problems, take it with food. Afterwards, we're going to monitor intake and output, the urinary output, because we know it causes urinary retention. It dries you up, especially our medications. We've got to watch for that. We want to make sure they do a daily weight. If you're on disopyramide or Norpace, we're going to watch for signs of heart failure. And if you take digoxin with these meds, it actually can make digtoxicity. So it can cause digtoxicity if you take this class of medications with dig. So it's probably not a good idea to do that. Teach the patients to watch for their urine output because we know it can cause retention. Report a weight gain of more than 2 pounds per day. Teach them the signs of heart failure. We want them to take the drugs every day at the same time. Stay out of the sun if you're on disopyramide because remember the drying effects, so that means you're not going to be sweating. If you're on quinidine, okay, you have to avoid those high alkaline ash foods like citrus fruit, milk, veggies, broccoli, cabbage, carrots. They will interfere with the excretion of this drug and can cause toxic levels. And no St. John's wort when taking quinidine because it will actually decrease the blood level of that drug. So no St. John's Wort with that quinidine. Older population, higher risk for side effects and toxicity because they eliminate more of the drugs more slowly. So we need to monitor definitely the urine output because those are usually the population that have issues, the male populations with their prostates. So that is your class 1B sodium channel blockers. Now, or your 1A, sorry. Now we're talking about 1B. Go figure. Now your 1B, these ones will treat symptomatic ventricular tachycardia, preventricular contractions, and they also are used to treat ventricular fibrillation. They inhibit the ventricles to contract prematurely, so they don't want that extra beat that occurs. And on page 302, is some of our common medications. Lidocaine, big one that we did. And also, if you notice, phenytoin's in there. Phenytoin is actually a drug that we use for seizures, a dilantin, but it's also used as an anti-dysrhythmic drug. It is, we don't use it very often for that purpose. Usually, if we're going to use it, we're going to use it for seizures. But probably the biggest one I've given is lidocaine, and actually gave it over the weekend to a patient. That was having runs of ventricular tachycardia. He'd be in sinus tach, then he'd have run of ventricular tachycardia, and then we would have to. So we gave him some lidocaine and started him on a lidocaine drip. So these ones are the common ones, like I said. If the patient is in VTAC, a lot of times they'll give amiodarone or cortisone. That is usually our first line of treatment. But they may follow up with lidocaine or xylocaine. Now, lidocaine is given IV, or we can give it, remember, it's one of our naval drugs, L for lidocaine. So we will give it through the endotracheal tube if we do not have an IV site. We can give it IM, we can do an intermuscular only in emergency situations. We never ever give lidocaine to patients with severe heart block. It can cause so many problems for them. The side effects, and that is on page 302, a lot of neurological issues, confusion, drowsiness. It can cause a lot of dizziness, tremors, vertigo, visual problems, and tinnitus, that ringing in the ear. And it can cause some burning at the IV site. Adverse effects, cardiac arrest. It actually can make some of the dysrhythmias worse. Some of the meds can cause pneumonitis, pulmonary fibrosis, or pulmonary edema, so we do have to watch the respiratory status. And few of these drugs can cause neutropenia, and we know if that happens, they have to stay out away from those dirty little grandkids and out of crowds, which everyone should be doing right now because they are at high risk for infection. And we know phenytoin, which is dilantin, if they do give it, it can cause aplastic anemia as well as Stevie J. So we get Stevens-Johnson syndrome. So before we give these meds, remember that St. John's wort can decrease the level of lidocaine in the blood. So it is not recommended St. John's wort with lidocaine. We want to make sure we have a good IV site before we give these medications. Afterwards, we're always going to make sure they report any complaints of chest pain or shortness of breath, because this could be signs of heart failure. Report any of those side effects that are occurring. And we want to make sure, if they're on a lidocaine drip, that we have the patient report if they have any numbness at the IV site. Because lidocaine is actually what we use as a numbing agent for people who need sutures. We will give them lidocaine, and then that numbs them up, and then we can, sew up their little boo-boos. Now, if the IV gets infiltrated, the patient is going to complain of numbness because it's lidocaine. So it's going to numb the area. And that's what we want. So if they start complaining of numbness around the IV site, check it, because it may need change, and that it could be that the IV has infiltrated. Also, we want to make sure we watch for any decreased heart rate and asystole, which is flatline, with hypotension and also shock. So those are some things we have to monitor. And we want to make sure we tell the patient to report irregular rhythms, heart rate less than 60 or greater than 100 beats per minute, chest pain, shortness of breath, or wheezing. Those are some things that we have to monitor, as well as have the patient warn us if any of those symptoms are occurring. Guess what? Not recommended for the breastfeeding pregnant population. In our older population, they're going to be at risk for falls due to dizziness. Those are the ones we're going to see more of those neurological effects, more like the confusion. So it's very important to know what their normal mental status changes before, because if they're confused, we may not know if it's a side effect or not. And then they're at high risk for lidocaine toxicity, and that is a sudden change in their level of consciousness, confusion, and their heart rate. So that is our class 1B sodium channel blockers to help with high heart rhythms and dysrhythmias that are high. Now our third class of our channel calcium blockers, our class 1Cs, those are to treat like ventricular tachycardia, VFib, SVT, that just won't go away when other drugs are used. And on page 303 are some of our common ones that we have, and that is flecainide and pafenolol with this Rhythmol, and that's probably the one we use the most. And if you see that last one, Rhythmol, it deals with the rhythm. These will help slow the electrical impulse of the heart, so it's going to lower the heart rate. And we usually give it by mouth, so it is a PO drug. But they do have side effects, and that is on page 303. It usually occurs more when the dose is increased. We'll see more of these side effects. But it can cause some dizziness. It can actually cause altered taste. It can cause nausea, vomiting, and constipation, and it can interfere with the conduction system and cause heart block. It does cause blurred visions and problems focusing, and issue with that is our people who have glaucoma. We have to watch anytime blurred vision. We have to watch our patients with glaucoma because it can interfere with their intraocular pressure. Adverse effects for this classification, it can cause SVT, supraventricular tachycardia, as well as ventricular rhythms. It can cause heart block and VTAC. Before we give these meds, if they have a history of bronchospasms, then they shouldn't take these profenol or Rhythmol because it can make issues worse. So we do not want to give it if they have bronchospasms. We're not going to give profenol. I'm screwing that up big time, huh? Or Rhythmol. So afterwards, we want to make sure we ask if they're having any side effects because it can lead to toxicity. We want to make sure we tell the patient to report anything to the doctor. In the older population, if they have liver and kidney problems, the doses are always going to be lower. And safety, safety, safety. They're at high risk for falling due to dizziness. So those are our class 1 calcium channel blockers. Now, and that's 1A, 2A, or 2B, or 1C, one of those things. But anyway, those are our class 1s that we're dealing with, and those are all calcium channel blockers. Now, the second class we're going to talk about is beta blockers. We already talked about beta blockers, and these are going to treat SVT, that's supraventricular tachycardia, which is a very high heart rate. And we discussed this, like I said, back in the chapter 16. It will help slow the ventricular contractions, and it's going to, be used a lot. So on page 305, the ones that we use a lot when it comes to dysrhythmias is propranolol and sotalol. Those probably are the two biggest ones that I've given before. And remember, it is a beta blocker, so a lot of times you're going to see that OL. But in this case, with the sotalol, it's ALOL. So remember, those are some things that we're looking for. A lot of times with our beta blockers, if you have kidney problems, they will give lower doses. And of course, our older population is also started on lower doses. But the signs and symptoms with it are what we learned back in chapter 16. We're going to see the same things for this chapter. It's just in this case, we're using them for high tachy dysrhythmias. Now the next one, the class threes, we already did class ones, which are calciums, class two, which is our betas. Now class three is our potassium channel blockers. And this will inhibit the potassium from moving into the cells. These are the ones that are going to treat your VTACs, your VFibs. They will convert atrial fibrillation to a flutter, to a sinus rhythm. And this, I know it sounds all foreign. Don't freak out on it. But our goal is to make it normal. We want a normal rhythm and back to the normal rate that it is. So we're trying to get that high rhythm and bring it back to a normal, correct rhythm. Now on page 305 at the bottom, these are common potassium channel blockers. And amiodarone, that is the biggest one on here that we will give, or cortisone, that we will give the big. Um, Phetalide or Ticacin, we had that out for a little while, but I haven't given it much recently. Usually amiodarone is now like the drug of choice. And then, of course, there is sotalol, which we also saw with the beta block. It is also a potassium channel blocker. Okay, so we have to remember that it has two. It has it blocks the betas, but it also blocks the potassium. Um, Usually the IV dose is to convert the patient out of a rhythm and to maintain a sinus rhythm. And then before they go home, the doses will give oral just to prevent them from going back into that bad rhythm so that they had prior. So they will usually give the first dose IV and then to get them out of the dysrhythmia, and then they will give them the PO dose to take home. All right, side effects for these. Flip the page to page 306. So our common side effects for our potassium channel blockers is there are some neurological issues. So dizziness, fatigue. These can drop your blood pressure, so hypotension, especially because we're giving them IV, those IV meds. It can slow the heart rate down because think about it. If we're blocking that potassium from getting into the heart, we know it causes those muscle contractions. It's going to slow the heart rate down. Okay, and that's what we expect to see. So bradycardia can occur. Sometimes you get tremors of the hand. You can get loss of appetite, the anorexia part, nausea, vomiting, constipation, and sometimes they can have an unsteady gait. So it does have a lot of effects on the body. It can cause amiodarone or cortisone can cause photosensitivity, peripheral neuropathy, and it can cause microdeposits of the medications on the cornea of your eyes. It can cause hypothyroidism, which a lot of times you'll see in the first few weeks of treatment. So you will see a change in the heart rate. So if they have hypothyroidism that you're going to see when you're taking this medication, their heart rate will decrease down because everything slows down. And long-term use, it can actually cause blue discoloration of the face, neck, and arms. Okay, so amiodarone, photosensitivity, peripheral neuropathy can cause the microdeposits of the medication on the cornea. Hypothyroidism, especially we'll see it in the first few weeks of treatment, the heart rate will start to change and go down. Long-term use, they can get a blue discoloration of the face, neck, and arms. Okay, and that does go away once they're off the medication. Now, adverse effects for amiodarone, and amiodarone is the big one that we're going to be concentrating on for our potassium channel blockers. Amiodarone can cause ARDS, and that's adult respiratory distress syndrome. It can cause pulmonary fibrosis, heart failure, dysrhythmia worsening, decreased liver function, toxic epidermal necrolysis, and that's a skin disorder caused by an allergic reaction that can actually kill you. So amiodarone, excellent drug, but it does have nasty side effects and adverse effects that we do have to watch for. So before we give this, we want to make sure that we have a very, very good IV site before we give it. Afterwards, we're always going to monitor that IV site. If we're getting amiodarone, we're going to make sure we check the blood pressure frequently because we know it can lead to hypotension. We're going to make sure they're on a cardiac monitor so we can watch for change in the dysrhythmias if they're having any bradycardia. We're going to monitor the respiratory status because we know that amiodarone can cause ARDS. It can cause a lot of heart failure. So we want to make sure we listen to the lungs. It can cause dysrhythmias to become worse, so we're always looking for that. We're looking for signs of hypothyroidism because we know that it can occur within a 1 week after. So we want to make sure we do lab work for our electrolytes. We're going to do liver panel as well as a thyroid test to make sure our levels are good. And we should always do an EKG and make sure that we are treating the correct rhythm. We want to make sure we teach our patients to wear protective clothes when they go outside on these medications. Sometimes the side effects will not show up for several days or weeks. And like I said, long-term use, you'll have that blue color to the face, neck, and arms. And like I said, it is reversible. It will go away. Now, because amiodarone causes the corneal microdeposits of the medication on the eyes, they do recommend getting eye exams every 6 to 12 months. Another important thing about amiodarone is that it can cause pain and swelling to the scrotum on the male population. And this should be reported ASAP because if it does happen and they have swelling and pain in their um, testicles, we want to make sure we hold the dose and notify the doctor right away because that means that the dose of amiodarone is too high and we need to stop that medication. We need to get that dose lowered. Now, pregnant population, amiodarone is not recommended to breastfeed. In our older population and the pediatric population, we use these medications very cautiously. Now, the only way I can remember about amiodarone, and I keep adding things onto it, but it first started off with a blind blue Smurf with big blue balls. That's how I kind of remember amiodarone. All right, blind because they have the micro deposits of the thing. Blue because in long-term use they get that blue discoloration. And then of course the balls because if it's a male and if they get swelling of the testicles, we have to be very cautious and report it so they can decrease the dose and that swelling will go down. But I do need to add more things into it because we should have a slow for the hypothyroidism. So I may have to put in the slow, blind, blue Smurf with big blue balls. And I will add more onto it, but that is the way that I remember amiodarone. So if you can think of anything to add on to my amiodarone thing, add it on, but it is a good way of learning amiodarone. So I thought I'd share that one with you. Now, and next thing we're going to talk about, we already talked about our potassium channel blockers. We're going to talk about the class 4, which is our calcium channel blockers. Okay, and these ones, like I said, these are on page 307. And we talked about these already when we talked about back in the hypertension chapters. But diltiazem, which is cardizem, and verapamil. Okay, and these ones will we usually give lower doses that are prescribed, especially if you have liver or kidney problems. And we see a lot with decreased doses in our older population. Like I said, we already talked about that. Remember, it will decrease heart rate, so we expect that if it's for a high rhythm rate, we expect to give this because it will lower the heart rate. And verapamil, remember, big time with verapamil in the male population, it can cause breast enlargement and it can also cause Stevie J, so that's Steven Johnson syndrome. So look back in your hypertension chapter that we went through, and those will give you the common side effects and things we have to do for the class 4 calcium channel blockers. Now, there are a couple unclassified antidysrhythmic drugs that we use. And let me tell you, one of my favorite drugs to give is adenosine or adenocard. And that is on page 308. This medication treats people who are in supraventricular tachycardia. Sometimes their rates can be in the 200s. In this medication, it is given by nurses. We always make sure that the crash cart is at the bedside, and we make sure that the doctor is at the bedside. We never ever push this medication unless there is a physician in the room. It is a rapid injection. We have to give it very fast. So we have to make sure we have a very good IV site, and it has to be pushed within like seconds, 1 to 2 seconds to put it in. And then we have to flush it through with a rapid flush. So a lot of times we'll have one nurse at one port of the IV tubing and another nurse at the other port. And what will happen is the first nurse will push the med, the second nurse will push that IV fluid to get it in real quick because its half-life is very quick. Usually, what we're seeing is we're trying to break that patient's, if they're in true SVT, because some atrial fibrillation, they call it AFib RVR, atrial fibrillation with rapid ventricular response. Sometimes you'll get them together and they kind of look alike. And the only way of trying to figure it out is sometimes doing adenosine because it will kind of break down the rhythm and you can look at it. But if it's true SVT, you're going to have a brief period of asystole. Okay, and a lot of times it's very stressful for the patient when we're doing this. A lot of times we are telling family members to get out because they do not want to watch this. So we want to make sure that we put the defibrillator on the patient. We want to make sure that we put, give the patient some oxygen. Sometimes we'll even give them a little bit of stuff to help relax them, but usually at this time we don't have enough time to do that. We want to get these meds in to get that rhythm down because it's too fast. So they will have a brief period of asystole, and at that time, the patient is going to complain, and a lot of times they say it feels like they're getting kicked in the chest by a mule, but their heart will flatline. And then it will start beating again. That is why we never, ever, ever push this med without a physician with us. Usually it's in 3 doses. It's a dose of 6 mg, then we give 12 mg, and then we repeat 12 mg. If it's true SVT, it will go down, and sometimes we can see if it's atrial fibrillation, then we're probably going to give diltiazem or cardizem to help with that. But a lot of times, the patient's side effects with it, and you can see that on page 308, patients will complain of facial flushing, shortness of breath, and we actually can cause some dysrhythmias, either AFib or A-flutter. But like I said, that can occur. Now, adverse effects. We would never, ever, ever want to give this patient to anybody in heart block because unless you are being paced, it can cause asystole and kill the patient. So we would never want to give it to anybody who is in heart block. We would never want to give it to anybody in cardiac arrest, anybody in sustained VTAC, or anybody who has a non-fatal myocardial infarct, unstable angina or angina. These patients are at greater risk, so we would never want to give it to anything like that. But like I said, it's very scary for the patient because we are actually stopping their heart, and sometimes you get a little nervous. It's like, oh, oh, their heartbeat's not beating. And then all of a sudden it starts beating. You're like, ooh, thank goodness. But it's interesting to see, but it can be scary also for the patient. And a lot of teaching and talking to the patient, trying to soothe them, tell them take some deep breaths. Take some deep breaths. Okay, you're going back. And sometimes it will break the dysrhythmia, and sometimes we have to do a couple doses. But this is something, like I said, you have to be very cautious with. So if this ever happens and you're able to see it, you will enjoy it. Well, not enjoy it, but enjoy seeing the process of it. But always, like I said, crash cart and defibrillator at the bedside before we give the med. We're going to inform them that it is a short period where their heart will stop beating. It will feel like they're being kicked in the chest by a mule. And what it is their heart is going to try to get back into a normal rhythm. We want a good IV site, and like I said, that doctor better be at the bedside because we would never give it without him. Afterwards, we're going to make sure we monitor blood pressure every 15 to 30 minutes. We're going to watch the heart monitor for any rhythm changes, and we're going to make sure we teach the patient any problems, any change in condition, if you're short of breath, because it can cause shortness of breath, dysrhythmias, as well as facial flushing, to report that when they're on there. And like I said, if we give 12 milligrams or more, it can cause hypotension, so we do need to watch changing positions. And the last thing that we're going to talk about on this is, of course, our magnesium sulfate. Now, magnesium sulfate is treat torsades de pront, and that is just a different dysrhythmia. And a lot of times we see it after a patient is intubated, and if that occurs, then what we do is we can see this weird wavelength, and we can actually know, hey, they're magnesium deficient, so we will give actually magnesium for it. Remember, we know this is a mineral in the body, and on page 309 is the magnesium dose that we would give IV, and an RN would be given that, as well as she would be given the Adenocard from the last thing we talked about. The patient needs to be put on a monitor while they're on it. Sometimes, like I said, we usually see that weird, unique pattern after we defibrillate a patient. And we will talk of we already talked about magnesium back in the last chapter on 17. Now remember, with magnesium, very upsetting. That is the Taco Tuesday of all Taco Tuesdays. Magnesium, a lot of people don't understand when they're given magnesium, it will make them poop. They will shit themselves big time. Think about people who take magnesium citrate if they are constipated. If we give it IV, they're going to poop a lot. So expect to see diarrhea with magnesium. It is the Taco Tuesday of all Taco Tuesday. Now, there are other drugs that we can use for dysrhythmias. We can use anticoagulation drugs, and those are to prevent blood clots that can form in patients that have that atrial fibrillation, where the atrium is just fibrillating. It's not squeezing, but just fibrillating. We can also use heparin or warfarin, which is Coumadin, and we're going to talk about that actually in chapter 20. Another thing I want to put in, and which I didn't talk about, but usually when I see it, I would. We talk about something called MONA for people who have myocardial infarcts or that have heart attacks. We always want to use the acronym MONA, and that is the treatment that we should give for anybody who comes in with having a myocardial infarct. We want to make sure that we give them morphine because that's going to help with the heart. We want to make sure we give them oxygen. They need that oxygenation. We're going to give them nitroglycerin. That's the vasodilatator we talked about, and that's going to help open up the blood vessels, get the blood flowing. Plus, remember, it's good for the coronary arteries. So if we get those vessels open, get that blood to that coronary arteries, it's going to be better on to the heart. And we also want to make sure that we give the patient aspirin, give them an antiplatelet drug. So I thought I'd throw that in because I always forget to mention it, and I wrote it down on the end. It says MONA for MONA. That is the treatment of choice for people who are coming in for cardiac issues. So that is chapter 18. If you have any questions, message me. Have a good one, guys.